Okay, can you hear me? Great. Wonderful. Oh, well, hello again. Welcome. Just give you some time to get seated and we will get started. Well, welcome to this panel discussion. Now it's going to be around transplantation, particularly pre and post-transplant, and all the element of adaptation that requires either before or post, because these are quite different way of life before and after transplant. So I'm happy to be joined by two healthcare professionals. First, Anne-Marie Russell, who you most of us probably know already. She's a professor of ILD symptom science at the University of Birmingham and a clinician at the NHS Regional Specialist Centre. She also has been with the UPFF for, well, since the beginning, haven't you, Anne-Marie? Now we have to my right, Rasleen Kaha. She is a highly specialized respiratory dietitian at the Royal Brompton Hospital in London. And she has led, and that's important, she has led the first known research on dietetic care for malnourished patients with ILD. So she's going to tell you a lot about that in a minute. She sits on the Council for Healthcare Professionals for Asthma and Lung UK. And she's also a trustee for the Alexandra Rose charity, which provides families on low income access to fruit and vegetables. And now we also have two patients, ILD or IPF patients, and they will tell you how they cope with their condition. First, well, just one word of caution there. Alba, thank you for telling me. The tips that you're going to listen to in a minute, well, they are very personal, and they do not replace medical advice. So in case of any doubt, just consult your physician. Now, Stefano, he's to my right. He is a double lung transplant recipient from 2012, I believe. He was suffering from cystic fibrosis, and he's been a UPFF director for 6 years, and he also runs an Italian patient organization that focuses on transplantation and rare lung diseases. To my right, John Solheim, you've met him just between those two nice green leaves. John is a pulmonary fibrosis patient from Norway, has been engaged in patient advocacy since 2018, and he is also an active member of the UPFF board of directors, and also of his Norwegian Patient Association, sorry. So during this session, what will you hear? First, you will be given an update on transplantation. Then you will find out how important nutrition is for ILD patients. And then our two patients here will tell you a bit about their conditions and the way they cope with their conditions pre and post-transplant. And the last 10 minutes of the session will be devoted to questions and answers from you and from our online patients and assistants. So let's start with you, Anne-Marie. The floor is yours.
Ooh, wrong way. Lovely. Green for go, red for back. Thank you, John. And thank you very much for that lovely introduction, Chantal. And just a reminder that this session is about living well before and after transplant. So our focus is very much going to remain there. This is who I am, as just an excuse to show this beautiful picture and remind ourselves of the architecture of the lung, which I think is quite stunning. So just to start by thinking about where we have been and where we have come, the EU PFF is celebrating its 10-year anniversary. It's over 60 years since the first successful lung transplant was conducted at the University of Mississippi. And we've learned a lot over time, particularly around patient and donor selection. We had a lung allocation score, which helps with that, and that was recently revised in 2023. We've learnt a lot about organ retrieval and organ preservation, and we now have ex vivo approaches where previous rejected lungs now have an extended criteria and can be perfused, which enables more transplants to take place. Surgical techniques I cannot speak to, but they clearly evolve over time, as does perioperative management. And I think we are much more familiar with immunosuppression approaches and managing side effects. And so there's a positive outcome for patients in that regard. Lung transplants are very emotive, and I just want to take us back to think about, for anyone who's living with a life-limiting condition, if you're given a life-limiting diagnosis, it focuses your attention on mortality and it focuses your attention on the here and now. And we're going to talk a little bit about pathways later, but I think early diagnosis is key because it opens up those discussions to possibilities of optimal treatment. And as is access to good information, so that if we understand what the pathway is, if we understand that lung transplant might be on the table, then we can make good and informed decisions early on with our loved ones on board and supported for the whole of that journey. I think dignity and respect in the consultation go without saying, and that can be a little bit emotive when we come to talking about lung transplant and donated lungs, and so sensitivity is key. There is an information overload. I love the slide that John showed. So I think having information at the right time in the right place is important. And knowing through organisations like EU PFF and the smaller advocacy units what we can do to help ourselves, to keep ourselves fit and living well, so that if lung transplant is an option, we are in the best place to receive it. And again, we've got a sense of community here, a sense of belonging, and with friends who understand the challenges that we face. And if lung transplant isn't an option, the other thing we also think about, given a diagnosis of a life-limiting condition, is how we want our ending to be. And I strongly believe that every society should be judged on how it welcomes new life into the world through our maternity services and how we enable people to leave the world so that it is a positive experience as it can be for all concerned. And so a little bit of data here, which I've taken from the UK because that's where I work and practice. So you can see here that they were just short of 1,500 adult lung transplants performed in a 10-year period. So it is rare surgery. And we have a number of patients who remain on the list. Majority of transplants go to men with a median age of 56. And people who are on the waiting list are stratified using a scoring system according to level of urgency. Data is hard to get that's really up to date. So the 2024 figures show that there were just short of 260 people on the non-urgent list and just 5 on the urgent list. And thankfully none on the urgent super list at that time. So waiting is difficult. During waiting, you're managing uncertainty and contemplating, and waitlist times for any investigation, for any procedure are challenging. So thinking how we manage that is important, and we'll speak a little bit more to psychological processes around that. There are core things that influence that. I guess a key is availability of a donor organ, but also as a candidate, it's your primary diagnosis, your blood group and tissue typing. And there's also a little bit of variation between lung transplant centres, and that's something that we're getting a little bit better at collecting, but we do need to make it more publicly available. The other thing to think about are the number of lungs that are offered by donors and the number that are transplanted. We don't want to waste valuable organs. And there was a recent study done in Ohio that showed, I think it was a mean 60 transplants seems to be the cutoff for improving 5-year survival by about 7%. So we do need to focus attention in those specialist centres, and we need expert surgeons current with a training programme for new transplant surgeons to optimise the outcome. So along the patient pathway, which is complex, there's lots of touch points along that that create an appropriate opportunity to revisit discussions with clinicians about the possibility of lung transplantation. Ideally, it should be done around diagnosis, but during that workup and during that symptomology period, it is a time where we could think about exploring those options and relieve some of the stress further down the line. It's difficult because we have a little bit of an age cutoff, although there's been a lot of flexing with that, I would say, probably more so over the last decade. And so I've just put a list here of absolute and relative criteria for transplant consideration. And there is some evidence that we can look at physiological age, not just chronological age, in terms of success rate. And a lot of work has been done in Ireland looking at a physiological age, so for those above 65. Of course, body mass index is an important consideration, and I think that John's going to spend a little bit of time speaking to that, and nutrition is important there. But also underlying malignancy, which means often when you're being assessed for lung transplant, you may have to undergo further screening to ensure that there isn't an undiagnosed concomitant malignancy, and being prepared for that appropriately. Any renal compromise should be considered, as should liver and heart disease. And then again, you can see here, if we're looking at interstitial lung disease as subsets, the older we get, the more prevalent IPF becomes alongside unclassifiable disease and that greater level of uncertainty. And we know that frailty can occur with all conditions, but frailty tends to be more prevalent as we get older. And therefore paying attention to things such as pulmonary rehabilitation and keeping as fit and healthy as we can over time. And we can also see from this graph here that if we're looking at 65 as a cutoff, the majority of people receive or are living with a diagnosis of fibrotic lung disease over that age, with just the CTD being diagnosed a little bit earlier and sarcoidosis. Again, it goes without saying that the long-term survival, the younger and fitter you are, the better you're going to do. It's a fact of life, but there are things that we can do to mitigate that in terms of thinking about physiological age and preparation, which we're going to cover in this session. So other indications, absolute and relative, to think about are self-explanatory here. Connective tissue disease, it needs to be considered on a case-by-case basis. So it may be a relative indication because of the vascularity, but it's not necessarily an absolute contraindication. And it's thinking systematically through the whole body about systems that could impact survival post-transplant. And chest wall abnormalities we're seeing less of, but again need to be considered. We focus very much on functional status and psychological well-being. And it's imperative that prior to lung transplant, any smoking or substance misuse has been stopped for 6 months before. And that's not always easy for some people because there is an addictive nature. And in terms of the psychosocial preparation, it's essential to have family on board as well. It's not an easy process, and it's not just about the person, it's about the context of their life, and how the family are going to support and manage. So selecting the right patients for referral is key, not only for the patient, but for the outcome. And by the time you get there, it is because you have a diagnosis of irreversible lung pathology, and that you have both a physiological and psychological resilience to endure the process. And the majority of time for people living with pulmonary fibrosis, it's likely to be a single lung transplant. Double lung transplant tends to be more prevalent in younger populations than people with cystic fibrosis. That's not an absolute. People who have underlying pulmonary hypertension tend to do much better with a double lung transplant. But of course, in terms of supply and demand, if you have 2 donated lungs that could potentially prolong 2 lives, there's also the numbers to think about in terms of the approach as well. So in terms of interstitial lung disease, very much at the time of diagnosis, when a histopathological usual interstitial pneumonia is identified, and that is on the old criteria probable or definite UIP pattern. And certainly on pulmonary function testing, the FVC is important, and the transfer factor, the DLCO, also important. These are important criteria to think about referring at this point in time. And then patients need to be monitored. And sometimes home spirometry helps with that as well. It certainly did in COVID. Thinking about starting supplemental oxygen in a timely manner, it should be considered to maximise fitness and maximise activity around pulmonary rehabilitation, which of course is different pre-transplant in terms of thinking about capacity, whereas post-transplant we probably tend to focus a little bit more on endurance. And so oxygen assessments are key as well, and making an informed decision around that. And at diagnosis, thinking about familial pulmonary fibrosis tends to be in a younger population, but key to ensure that patients are referred promptly. And one way to do that might be involving the multidisciplinary team. So this is Lisa, who is our ILD, one of our ILD clinical nurse specialists at our centre in Birmingham. And Lisa set up a special clinic to support people who were potentially eligible for lung transplant referral. And you can see here, this is data that she presented at European Respiratory Society Congress. That in terms of there's been an increase since her clinic in the number of transplant referrals and the number of patients who've been transplanted over time. And there's a lot of paperwork to do in the transplant referral process. And having a dedicated clinic enables a really strong focus on the paperwork and the form filling. And if that is done accurately, then it is likely that the patient is going to be seen sooner. It also means that there is time for some counselling about the process. There's time to talk to family about the impact. And then the person who's been referred is very much a part of the interstitial lung disease team, even when they go over to be part of the transplant team. And so Lisa also makes sure that there is follow-up contact and care as well. So some of the key messages are the earlier the better. We need to get the pathways right, so we get the diagnosis early, and transplant should be considered very much at the beginning of the disease trajectory, and ruled out rather than ruled in. We do need to think about patient selection. And so the onus is also on us as clinicians to be thinking holistically of assessment and not just focusing on the lungs, because of bodily systems can get in the way if the patient is otherwise a good candidate for lung transplantation. Care should be individualised. People respond differently to surgical intervention. Some people end up on the list but don't always receive a transplant, and so we need to be mindful of the appropriate psychosocial and physiological care during that course. And despite ex vivo approaches, you know, the demand for lung transplantation vastly does exceed supply. And so we have seen a huge transition across Europe in terms of most countries now have an opt-out for organ donation. I was talking to Maureen at the break. I think that came on board in Ireland just last year. Even if you have an opt-out, it doesn't necessarily mean that a potential donor will give those organs, because there can also be preferred consent and informed consent with the family. I think it's only perhaps in Germany where implicit consent is taken from not opting out, and that might be Austria as well. And in terms of the European countries with the highest rates of transplant or with the highest rate of donation is at the minute Brussels, Spain and Portugal. So there are maybe things that we can do looking at their model to improve matters. We haven't talked so much about post-transplant care, but happy to take questions on that after Stefano's talk. But I can't emphasize enough the importance of lung transplantation being a multidisciplinary effort from primary care through to secondary tertiary care, including all members of the interdisciplinary team, including dietitian, including the clinical nurse specialists, the patient and family, and it's a way to ensure that communication channels stay open. And I think we all know that without good communication, things often fall apart despite excellent surgery. So thank you very much.
Thank you, Anne-Marie. Well, thank you for this excellent overview. We'll skip the questions for now because Stefano's time to tell us about some tips that he has appreciated during his condition pre and after transplant. So Stefano, please, we are a bit short on timing, so we'll keep the questions for afterwards.
Good evening. Good evening.
Anyway, it's okay.
I'm Stefano. I'm going to tell some tips for making the most of your transplant. Some tips are from my experience, but also from the one of my friends and fellow that made the transplant in this last period. The first phase is preparing for the lung transplant. It's important that you follow every advice from your doctors. You have to adhere to the test, the treatments, and any advice provided by your medical team. This is for ensuring the safety and the success during the pre-transplantation process, which is very difficult. You have to maintain a healthy lifestyle, adopting healthy habits, obviously avoiding smoking, but sometimes it happens, and take part in appropriate physical activities to prepare your body for the lung transplant, because it seems strange, but for having a successful transplantation, you have to be fit. You have to follow hygiene rules and monitor your symptoms and report them to your medical team to give them the possibility um, to see your conditions, because there's if the progression of your disease is very fast, there's the possibility to enter in the urgent list. And last but not least, you have to prepare mentally for the event, an event that will revolutionize your life. There are no rules. It's essential that you have confidence of the doctor and of the choose you make. Um, you have you have to follow the decision of doctors and your advice. And it's important to be confident of your choice and all of the center and the doctor you have choose. The crucial role of the carer. Um, the caregiver provides practical and constant support throughout all the transplant process, facilitating daily activities and care. Family also support and strengthen the patient motivation and contributes to the emotional well-being during treatment. Um, Carer and the family assure you a calm and supportive environment that improves the treatment of your treatments and the quality of life after transplant. It's important to say that very often the lack of a partner or caregiver or a family structure can be factors hindering inclusion in the transplant waiting list. So it's to take into consideration the importance of a family, of a carer. The post-transplant period is very important. I mean, your life changed totally, and very often you do 2 steps forward and 1 backward, but you have to maintain a positive mind helps in order to overcome these difficulties that might follow the transplant. Um, I can assure you that during the first year, something always happens. So you have to be prepared to to go on even if you find these problems. It's important to work with the medical staff, working with them, following their advice, and above all, to ensure a good recovery from the complications. And then the emotional support from your family, from the psychologist, who is essential in a transplant center, and also the period in the intensive care, which is particularly hard. This is my personal case. I have to say that mine was a successful transplant. So maybe my tips can be a little bit more optimist than the normal. But after my transplantation, I had the possibility to travel a lot, and this is all the magnets I have in my kitchen, and these are all travels I made after the transplantation. And my second activity after transplantation was the advocacy activity, which is very important for me, and for me is a way to thank for the luck I had and for the person who gave me the possibility to be here and to live. Your life after the transplant can be short, can be longer, you don't know it. But you have to celebrate every small step, every small goal that you achieve, and with sense of motivation. You have to appreciate every single moment and live the present, recognizing the quality of your life and cultivate gratitude for because not everyone have the luck that, for example, I had. Sometimes it's very hard. You have to reduce anxiety and promoting balance. Don't think too much about the future. Try to reduce anxiety and promoting serenity and emotional balance. Everyone will adopt their own strategies. Someone like me will get involved in community work, seeking to give back kindness because we received a lot of kindness. Other people instead will distance themselves from fellow transplant recipients to avoid hearing bad news. It's up to our way of thinking. I thank you. Sorry if I've been a little more, a little anxious, but it's not easy to speak about something like a new life. Thank you.
Thank you, Stefano. On your way back and before Raslin goes over there to explain, I see that you have traveled extensively. Just one or two practical tricks on how to travel safely. Yeah, just while Raslin is moving over there.
I think that if you decide to make a transplant, which is not easy, you don't have to live like you are you are ill. You have to try to live at maximum like everyone else, taking some I mean, you have to be safe, but don't have limits because you have to take the most of your second life.
Thank you. And thank you also for talking about carers. Raslin, it's your turn. We are going to hear about dietitian and nutrition. And here you go, Raslin.
Thank you so much for having me. I just wanted to thank the EUPFF for the kind invitation. My name's Raz and I'm a respiratory dietitian. I primarily work with ILD patients pre-transplant, and I'm going to talk a little bit about nutrition. Nutrition is a very big topic into itself. It can be about an hour, so I'm just going to focus on how best to live well. These are my conflicts of interest. So when I think about what's the key to living well in ILD, the key is really trying to maintain your muscle mass, and that's irrespective of whether you might be in a category where you're trying to lose weight or gain weight. If we take weight out of the equation, we need to move forward and think about how to maintain our muscle. Muscle is really important for you to do your day-to-day living, so to do your exercise, to be able to get up and about. But also we do know that if you have more muscle around your lungs, the intercostal muscles and the diaphragm muscles, that can be associated with a better breathing or FEV1. And so sometimes for some people, focusing on weight isn't particularly helpful. It can be quite binary and black and white. And so if there's something else you want to focus on, muscle is the best way to measure it. In the UK, we're particularly very poor at measuring muscle. Europe and globally, they have a lot better machines to measure muscle, but we are slowly getting there, and we are beginning to measure this a little bit more at the Brompton specifically. So you might be asking, okay, well, how can I maintain muscle mass with ILD? The first thing I always tend to do, and especially as a dietitian, our role is very holistic. So we first have to tackle any nutrition-related symptoms in ILD or nutrition impact symptoms. And I'm just going to go through some of these. Some of these may resonate with you, some of these might not. But a lot of the patients I primarily see are patients who've lost weight unintentionally, and typically through weight loss, they would have lost some muscle as well. And the reason that's really important is because weight loss is a huge part of people's identity. I remember I had a patient who told me that since they lost a lot of weight, their friends would call them skelly, short for skeleton. And so it's a big part of people's identity, and that's why it matters so much. Poor appetite is another one. So with inflammation, we know that that can send signals to the brain, dampening down the appetite processes. And so there is a legitimate reason if you have a poor appetite as to why that is. And again, poor appetite is a very debilitating symptom. We forget. I know for me, when I'm happy, I eat. When I'm sad, I eat. When I go out with friends, I eat. Eating is central, and imagine if that time when you've had that cold or that flu, and then you've got that chronically, and you're expected to go out for Christmas, go out to eat lunch with your friends. It's a really debilitating symptom, and at the moment, it can be quite tricky as to how to best treat it. Some of the advice we might say is things like eating little and often to re-stretch out the stomach, but that can be pretty challenging as well when you don't really feel hungry. Psychological state is really important, so we know that there is a bi-directional link between depression and poor nutrition. So if you're depressed, you're more likely to have a poor nutrition, but if you've got a poor nutrition, you're more likely to be depressed as well. And we do know that some medications, for example, mirtazapine, can help stimulate appetite, which might be good for some patients, but for other patients, that might not be good. Reflux is a really important one. Everyone probably knows that we have a very low threshold to treat reflux in ILD because we get worried about acid coming up and potentially going into the lungs. Diet can play a bit of a role. Sometimes things like high fat or certain acidic foods like juice can cause reflux, and we do worry that if you've got reflux on a longer term period, it can cause dysphagia, which just means issues swallowing. So we would always treat that very early. Taste changes. So a lot of the patients I see have experienced taste changes. Food can taste bland. They might have deficiencies. We always check things like B12 and zinc. And just to hammer home the point, Linda, I hope you have got your colleagues ready. So I've got a little bit of a practical for everyone. So Linda and her team are going to give round giving sweets out. I know a dietitian giving sweets, God forbid. And I've also got some for you guys over here. So what I want you to do is to plug your nose and close your eyes and eat a sweet. And what you will probably find is you won't be able to taste the flavor. So we do know that smell is really important in taste. And just to explain a little bit about what some of our patients are experiencing, yes, close your eyes so you don't know which flavor it is. So literally plug your nose, close your eyes, and eat the sweet. You'll be able to probably taste it sweet, but you probably won't be able to taste whether it's strawberry, lime, raspberry, whatever the flavor is. And that's just a little bit. And imagine living with that again chronically. So it can be quite difficult to then enjoy your food. Gastro-related symptoms are a really big one. So we know that antifibrotic medication can cause things like diarrhea, but also sometimes constipation. We might be giving dietary advice out. The British Dietetic Association has just come out with constipation guidelines. So things like 2 to 3 kiwis a day, 8 prunes per day. And we would also look at how best to prevent diarrhea in regards to malabsorption of food. Shortness of breath and cough. So for every time someone's coughing, they're burning 2 to 3 calories on average. So again, you have increased energy expenditure, and it can be really hard to support your shortness of breath and swallow. And so again, we'll look at things like more moist foods. I mentioned antifibrotics. A lot of the symptoms are related to gastro-related symptoms and poor appetite. Dry mouth is a big one, especially if you're someone using oxygen or you're really short of breath. Things which we usually advise are things like hard-boiled sweets, chewing gum, freezing segments of lemon and orange. That can be really helpful, and we'll use things like artificial saliva. And the last one that we consider is fatigue and food insecurity. What is healthy for you right now might not be healthy for you before what you were told with ILD. And so if you're fatigued, you might want to consider more things like ready meals or pre-prepared foods. And actually, we need to be giving permission for people to do that so they're not tired. You will only have a certain amount of energy in the day, and is food one that you want to be considering? So some people will say, what if there are no nutritional issues for patients, or what diet should I follow post-transplant? Every country will have their own version of this. This is the UK Eat Well Guide. And generally, if there's no sort of issues, this is what we would generally be recommending people to eat: a healthy, balanced diet. There are some caveats, and I will come on to that post-transplant. Just to say that UK is we're a very diverse population, so my job is not to judge what people are eating. We have patients who are from African, Caribbean, South Asian, and also patients who are vegan, and so my job is not to judge that, it's just to figure out what are the best types of foods that they can have. If people are struggling to keep weight up, what we generally recommend is what's called food fortification. This is from George's Marvelous Medicine, so it's trying to think about how to bulk up the meal that you're having without increasing the portion size so it's not overfacing. And that might be, for example, in the UK, we often use something like fortified milk, where you add skimmed milk powder to a pint of full-fat milk so that you can add some extra calories and protein into it. We would also think about oral nutritional supplement drinks, and there are lots of different types of oral nutritional supplements, which might hopefully work for different people. I should have probably have done a bit of a trigger warning here. In very rare cases, but I did want to talk about this, we might need to consider artificial feeding or enteral approaches, and this is where a feeding tube is placed directly into someone's stomach, and that's to artificially feed them, primarily overnight, so that they can get their extra nutrition that way, and that's to support their weight going up to a BMI of 18.5, like Anne-Marie said. Thinking about the other way and considering healthy habits, we do know that physical activity can be challenging for people who are short of breath, and also steroids can increase appetite, particularly for foods which are high in fat, sugar and salt. Poor sleep is associated with increased intake, and there's also a risk of diabetes, and we know on a long-term basis using steroids can alter muscle function and structure, so actually your muscles will be weaker over time. In terms of what could be helpful for people who are trying to lose weight, because muscle is so important, a joint approach with physio is really important. Some things that we like to focus on, instead of what foods to be taken away, what foods to be added. Protein is the most satiating macronutrient and keeps your muscles strong. Healthy fats are really good. Fluid, because sometimes when you're hungry, you're thirsty. And fibre, because it will keep you fuller for longer. And in the UK, we only eat 18 grams of fibre on average, and we should be eating 30 grams. This was just my last slide about post-lung transplant. Yes, ideally kind of focusing on the healthy UK Eat Well guide. However, we need to think about immunosuppression, and there might be some foods, for example, like grapefruit and Seville oranges, which you can't have because they might interact with medications, but also the 4 C's are really important. So the idea is to really try and avoid any kind of food poisoning, because that would mean if you get diarrhea or vomiting, you will that will affect how you're absorbing the immunosuppression drugs. So cleaning is really important. I know a bit of a boring one, but cleaning your hands, cleaning the surfaces, cleaning anything that you're doing, and making sure you're cleaning between cooking as well. Cooking and making sure food is really, really hot, so at least 60 degrees. You want to make sure you're not having any kind of pink meat is really important. Chilling food down, so having a thermometer in your freezer which is showing -18 or 0 to 5 in your fridge. If you're taking food out of the fridge, eating it within a couple of hours, chilling food straight away, but then only reheating it once, again up to 60 degrees, but then not further. And contamination is just really important. So again, washing hands is really important, but if you're cooking with something like meat, it's not washing it beforehand, it's putting it straight in the oven or straight cooking it so that it will kill the bacteria. And those 4 C's are going to be really important for people post-transplant. Thank you, and that's all I have to say.
Well, thank you, Raslin. It was an excellent presentation. Sorry, I'm still sucking on your orange tasting sweet there. I just wanted to ask you to give you a special thanks for the nice menu that you suggested for us. And I really think you deserve to be an applause. Thank you. Such a nice idea. John, that's your turn, my dear. And John, he's pre-transplant, so he will tell you about how pre-transplant people cope with their condition.
I must say, thank you, Rosaline. That was a quite inspiring talk, and you know that you and I have had a much fun. And looking at me, you should have found another poster patient when the two first slides are on weight loss and poor eating habits. Yes, okay. Thank you. No, heading for a lung transplant, I'm not there yet. So I really don't know what I'm talking about. It's a journey, and I don't know how long. This is very individual. We got common traits, but it's individual how our bodies are performing. So this, I don't know. What I know is that it's a balance, not too soon and not too late. It's just about the right time, because a lung transplant is not just a treatment, it's a life-saving option. They're not giving us a lung transplant before they see that, you know what, this is the only choice, this is the alternative you've got. Lungs are in short supply and in great demand. That also means I'm a registered organ donor, are you? My lungs probably just science will like to have, but they can have my hernias, they can have my heart, I got a strong heart. So basically, this goes out to all of you. All my family members are on the organ donor list, so they can provide organ donors. So that's my challenge to you as well. Time for reflection. What questions should I be asking myself? And giving one of the previous things is, if science develop a medication that can stop the progression in pulmonary fibrosis, would I really then like to go through with a lung transplant? I know that I can live like I do today for the rest of my life without having a lung transplant. But again, it's individual, and it's a more philosophical question. Involve your loved ones in your thought process. Why? Because as I always say, if you don't tell how you're feeling, what you're thinking, you're leaving the history, the creation of the history, to somebody else. And their story is often worse than how you really feel. That means you have to involve the ones that you are most connected to. The puzzle, it's complicated. Matching donor lungs, this has been touched on more than once today. Matching donor lungs with the recipient is a complicated puzzle where all pieces needs to match more or less. Says there, inclusion and exclusion criteria, and here's my bridge to Raz's presentation, and why the number 18 is significant to me. To meet the criteria and to be eligible for a lung transplant, I have two choices. I need either to grow 18 centimeters in height, or I need to lose 18 kilograms in weight. I've not decided which route to go yet, but I believe that the loss of weight would probably be the easiest.
That would hurt less.
Yes, it probably is. This is also what my doctors tell you. John, prepare before you have to. Okay. Why should I, as a pre-transplantee, care about post-transplant thoughts. Before transplant, making the cut, as an athlete would say, I would like to go to the next round, or becoming eligible is the physical thing. But how can I prepare? What if things doesn't go as planned? How can I prepare beforehand for what comes after? How will I manage after transplant? I would more happy with how will I manage risks and requirements. As Stefano also said, and others, there are requirements, how to live wisely, and there are risks, how to mitigate the risks. Am I willing to do that? These is the kind of thoughts that I need to think about even before I'm eligible for a transplant. And what will my new life look like, and how would others see me? Mine expectations are other people's expectations. I've talked to a couple of transplantees which have received transplant, and they're really saying, I need to learn myself all over again. What do I want to meet? Other people's expectations or my own? What are the expectations? What are my expectations? And my advice to you, no matter what, is be gentle to yourself, because you are the only one that you have. Think about your dreams and goals. What would I be happy with? Are you really looking to on the left side? Or would you be happy with the right side of the slide? I know my answer. And this, I would like to stop off with the quote from a Swedish poet. Remember, that's but my wife, by the way. She's not here now, but she's in the venue. Remember, you're not alone. That's not this poet quote. He says, one day we shall all die, but all other days we shall live, and we shall live well. So remember that. That is most important thing I wanted to take away from this session from me, is that everybody's gonna die someday. We don't know when. I can be hit by a streetcar when I go out here today. I don't know that. Just make sure that you live all the other days. Thank you.
Thank you, John. That was an insightful presentation. Anne-Marie, maybe just a few words now. Your medical comments or your advice, taking stock of the experience of those two healthcare patients and healthcare professionals.
Thank you. I don't know if my microphone is on. Yeah.
It is,
okay.
yes.
Really good presentations. I have to ask John, first of all, I can't remember the author of Sophie's World, but was that Norwegian, a philosophical book for children?
The quote?
No, I don't know if you've come across the novel Sophie's World, which is
Yes.
yeah, I thought so. So there must be something about that makes Norwegians philosophical. So thank you. And I think the philosophy of thinking about lung transplant is very important. It's a time to reflect and to consider options and how that impacts not only on one as an individual, but on family life as well. I think, Raslene, really important to think that nutrition is and weight is not just about a number. It's an awful lot more than that. And to think of adding and not taking away is an important lesson for us all to take back. And paying attention, I think that's a key message to taking stock of our physicality, our psychological and physical well-being. What can we do now to optimize ourselves for future choices? And I think that's not just a lesson for patients, it's a lesson for all of us in life, because none of us know what is around the corner. I sincerely hope you won't get hit by a streetcar because you've got duties and responsibilities the next 2 days, John. And I think, Stefano, your message is very important, that one can feel that the world is shrinking at times, but post-transplant is an extension of life, and carpe diem is what I take from what you spoke to, that we have to seize the day, and we have to live life and be cautious and be careful, and to talk to our friends and families about the importance of organ donation.
Thank you, Anne-Marie. Now, I think we'll open the floor to questions from the public, online, on site. So your questions are welcome.
We have a question online. They're asking, what would it take to make the outcomes that matter most to patients, the outcomes we actually measure in the clinical trials?
I think this question is for you, Anne-Marie, I guess.
Sorry, can I just clarify that? So the patient outcomes for clinical trials, is that clinical trials per se or specific to transplant?
So the full question is that on the 9 outcome slide, 6 of the 9 are qualitative: dignity, self-management, enjoyment, community, support for loved ones, dying well. None of them appear as endpoints in these morning trials. What would it take to make the outcomes that matter most to patients the outcome we actually measure?
Okay, so I guess there's the qualitative measures, and there's also the metrics. Clearly the metrics are important, but I would speak to patient-reported measures, which include patient-reported outcomes, patient experience measures, and patient engagement measures. Essential that these are developed using concepts that come from patients who are living with a condition, and that the psychometrics that you apply to condensing some of those concepts into questions or statements on a patient-reported measure can give you some objective data about a subjective experience. So I think that in the context of the consultation, it's essential to be collecting patient-reported outcome data at every clinical visit, because that helps to shape the questions and it helps to understand what is important to patients alongside the metrics.
Thank you. More questions from online participant first?
Yes.
We have another one, and it says that, probably it was for Stefano, and it was saying that the footnote on your current slide, that the lack of a partner caregiver can hinder listing, maps onto the ISHLT psychological resilience criterion. What would it take to make the carer and the whole ecosystem around each patient visible in the record and not just assessed once at referral?
You have a choice.
Okay, can you please?
Yeah, so, sorry, could you just clarify the question a little?
I think they're asking about the psychosocial criteria to be eligible for transplant, about the fact that how can we make sure that the care and the whole ecosystem around each of the patient is more visible in the record and not just once, because at that one situation or when their assessment is done, it might not be captured correctly and that might be putting them not eligible or for transplant. So how can we make sure that the whole environment is properly analyzed so more patients are potentially eligible?
From from what I know, many patients, well, during the visit that you make before being allowed to enter in the transplant list, usually there's a talk with the psychologist, and he has to verify your confidence, but one of the things is is your family, is your carer, and sometimes it's some people has not made be eligible because they don't have a carer or a family who can assure the life which is necessary, especially the first the first year, the first years. And I agree because there are some cases of transplantation who technically went perfectly, but then the person when go home, it's the case of an old woman. The son don't give enough care to the patient, and the patient feel that he is abandoned, and they can die. I mean, if they enter in the mental, in a mental way that they are, there's no one who help him. So having a good care at home is very important and can put, don't have it, can put your transplant at risk.
Yeah, to us carer. I just want to add something to that, Stefano, is just leave it there. That carer and patient, they are a team, so they have to be listened to, both of them, when they go to see a doctor. This is important to have this listening capacity from the healthcare professionals, because we really are a team, and this is, well, this is a life-saving process, I believe. And I think John wants to say something to that as
Yes,
well.
I just want to say that in every parts of our societies, we always have a possibility to ask for a second opinion. We should be able to do that here as well if things change, not just because we don't like the decision, but if there is our faults or if circumstances change, you should be able to get a second opinion. And also, what I think they're looking for is stability a little bit over time, because you need a support network around you to be able to perform a successful transplantation. Thank you.
Go ahead.
I just wanted to add to that. I'm mindful that there's a parallel workshop going on looking at inequities in health, and maybe just to say that there's a study in Ohio that looked at minority groups, particularly people living in socioeconomic deprivation of Hispanic and non-Hispanic Black populations. And although a lot of work had been done to enable the referral rate to go up, the selection rates were quite poor, and some of that was to do also with levels of education and socioeconomic status.
Thank you, Anne-Marie. Now we're going to go over to the floor for questions, and we'll start with Gergely, I think, who just raised his hand.
Yeah, many thanks. We usually hear that actually transplantation is a swap of conditions. Would you mind commenting on this, please?
Could you precise your question?
Yeah, we usually hear that transplantation is actually a switch between different conditions. Would you mind commenting on this, please?
Oh yeah, I can comment on that, definitely. We were told when my husband Albert was transplanted, just before he was transplanted, the pulmonologist said, you replace an incurable illness by an illness that we can cure. And I want to amend that. You replace one incurable illness by a number of illnesses that can be cured. So definitely this is a different way of life. And this includes different types of problems. You can have, well, I'm not going to enumerate them then, because there are a number of them, but it goes with skin, kidney, probably your blood sugar, that kind of thing. That can change after transplant, and that has to be looked after. But the main thing is that you're alive. And you breathe freely. I mean, I think the organ that is the most healthy in a transplanted person, that's the lungs. So, are there other questions from the ground? Yeah, over there.
Hello, it's Claire Donahue from Pulmonary Fibrosis Northern Ireland. What can be done to improve access to transplant once patients have been assessed as eligible? Sadly, my husband passed away whilst on the transplant list, waiting for a transplant.
I just want to say, first of all, encourage everybody to become lung donors. That's the first good step, isn't it? Sorry, Anne.
Yeah, no, I mean, that's an important point. I guess one of the challenges, and I'm very sorry for your loss, one of the challenges is that demand exceeds supply. And I think that prior to the lung allocation scoring system, it was first come, first served. I think the lung allocation score has helped a little bit of an objective approach. So it's looking at an individual, but also their potential for life and survival post-lung transplant. And I think that was refined in 2023 to make it a more composite score. But it doesn't feel fair if you're on the receiving end and you're sitting and waiting. But I think the advent of the work around ex vivo perfusing lungs that previously would not have made the grade for transplant, but now with those techniques are much improved. We are adding to the pool, but we also need to be thinking about training the next generation and making sure that we've got the expertise in the lung transplant services to be available to deliver. I think we're learning a lot and we're changing, but we've a way to go.
May I add something very
Yes, sure, go ahead.
I think that it's also important to be referred to the transplant center in time. Very often the people die during the list because they have been put in the list too late when the disease was
Progressing.
too progressive. And so it's important to find the right period in which I refer the patient to the transplant center.
Jean-Michel, you want to ask a question?
Yeah, maybe a question to Anne-Marie. Is there some progress or research in the field of transplantation to improve long-term survival, first of all, and second of all, maybe in a second step, to get a kind of a re-engineering, not a last rescue help, but earlier in our disease.
So most of I'm not an expert in post-lung transplant, I have to say, and so there may be work ongoing that I'm not familiar with and very happy for someone to shout up if they're aware of studies. I think most of our work is looking at optimizing post-lung transplant outcomes. So a lot of it is around monitoring the use of home spirometry, for example, so you're picking up early detection of decline in FVC, looking at symptom monitoring and the use of patient-reported outcome data. So again, picking up early changing scores that can be indicative of early rejection. I think in terms of immunosuppression therapy, there have been some new drugs that have come on board, but that's the extent of my knowledge. I don't know if Helen would like to comment.
Careful.
So I know from the transplant service that we have at our hospital, there are ways of trying to modify the regime that you have of immunosuppression prior to getting a transplant to try and prevent acute rejection. And then there are studies ongoing trying to identify rejection earlier. And so one of the studies that I think is a global study is actually where they use a sample of skin from the donor, so the person who donates the lung, they use a sample of their skin and put that onto the recipient, so the person who gets the lung. They embed that onto their skin because you can see the reaction of the skin quicker and easier than you can see inside the lung. So there are developments like that ongoing. Yeah.
Well, we'll take one last question over there. Do you have a mic?
Yeah, he has a mic. Right
For
there.
me, yeah. Is there a risk that transplanted lung gets idiopathic lung fibrosis itself? And how big is that risk? And how do you manage, how do the follow-up and further treatment of the patient?
So I guess if you have had a single lung transplant, then the lung that remains, if it had fibrosis, then it would retain the fibrosis. Usually a prior assessment is done to ensure that the worst affected lung is the lung that is replaced. It doesn't always work that way. In terms of post-transplant complications, often there's acute and chronic rejection, but there is a condition that can develop that can cause fibrosis of the lung, and that's irreversible. So that's often in a case of acute rejection, but it's a slightly different fibrotic process. And so I guess the key is trying to monitor to prevent both acute and chronic rejection.
Well, I think we are going to stop now. I want to thank our 4 panelists for your intervention, for your very important messages. I think you have shed the light on the difficulties and the challenges, and you also brought solutions, which is very important as well. Thank you to the public for your questions and your interest. We hope that you have brought something important back to home after that. And finally, I want to talk to our patients and carers. I want to leave you the following message: remain positive, accept and enjoy a slower lifetime or lifestyle, enjoy simple pleasure, small moments, and may the force be with you.
And now we have a short break. And this time there is coffee. Sorry, before. There is coffee, there's waffles, there's fruit, so there's some snacks. 30 minutes, and then we'll be back here for the Boehringer Ingelheim Symposium, which will discuss voices that drive change, navigating the future of PF care together. So see you in 30 minutes.